My name is Amanda Sokolik. I'm an MLT in the CLS program at Winston-Salem State University. I'd like to talk about polycystic ovary syndrome and the diagnosing of it and the lack of a standardized panel of laboratory tests for diagnosing. First, PCOS is the most common reproductive endocrine and metabolic disorder in women of reproductive age. It affects 5 to 10% of women in reproductive age, and it can greatly affect or impact the quality of life of those that are affected. Symptoms can range from mild to more severe, and symptoms can include the following, but not all: ovarian cysts, infertility, acne, unwanted hair growth or loss, unwanted weight gain, increased risk of diabetes, cardiovascular disease, and mental health issues. With PCOS, diagnosing it, there are some difficulties. PCOS, there are no set laboratory panel of tests, and it can be based off of many different criteria determined by the physician. Most physicians use the Rotterdam or NIH criteria to give a diagnosis. You must meet 2 out of 3 of the criteria to be given a diagnosis, which is oliglio, anovulation, hyperandrogenism, and or polycystic ovaries. Also, clinical signs, symptoms, which would include the acne, the hair growth, the weight gain in the middle. There could be the radiological testing for cysts on the ovaries. And then, of course, there are a series of laboratory testing that can be done to rule other diagnoses out. But if we could standardize a panel of laboratory tests that was specific to PCOS, it would make diagnosing this for the female population a lot easier. There has been use of the anti-Müllerian hormone that has been aiding in identifying women who are at risk, as it has been found in 1/3 are positive for this. Ultrasound imaging can be used in conjunction with this. They also test with luteinizing hormone, follicle stimulating hormone. These could be used specifically. Right now, other tests that a lot of times are used in the diagnosis would be DHEAS, TSH, 17-OH progesterone. These are used to help aid in diagnosis, but more likely to rule out other disorders. In the method of study, this would be passive observation. We would audit any specimens received from outpatient physician offices of patients that were being screened for PCOS. We would focus on gathering data on the tests most commonly ordered and investigate how well they correlate to the eventual diagnosis. Patients will have the opportunity to consent and be involved. Exclusion criteria from the study would include patients who are currently, breastfeeding, obviously have a previous diagnosis, and any other related disorders such as Cushing's syndrome or any androgen-producing tumors, or patients receiving hormone replacement therapy. As previously mentioned, there are myriad of tests usually ordered for the diagnosis of PCOS. serum testosterone, estradiol, DHEAS, 17-OH progesterone, luteinizing hormone, follicle stimulating hormone, and anti-Müllerian hormone and prolactin. And like I said before, some of these are not necessarily for diagnosis, but for ruling out. TSH is used not to really diagnose, but to rule out thyroid dysfunction. Serum testosterone and DHEAS are used to help rule out androgen-producing tumors. Prolactin is typically used to rule out hyperprolactemia, and 17-OH progesterone to exclude congenital adrenal hyperplasia. LH, FSH, and anti-Müllerian are more specific for PCOS. All specimens will be the original specimens and performed using established assays on the Beckman-Coulter Unicell DXL 800. Once data has been gathered from a minimum of 120 patients, frequency data will be determined using the chi-square test with a statistical significance determined of p less than 0.05. All specimens, let me not do that. From the information that we will gather from the study, I think we could create a panel of tests that are more specific in diagnosing of PCOS. This panel of testing would safely give a diagnosis without guessing and ruling out a bunch of other disorders. This panel of tests would include luteinizing hormone, follicle stimulating hormone, and anti-Müllerian hormone. All of these three tests would have a p-value of 0.01, leading to the rejection of the null hypothesis. And on the following slides are the references used for the information previously mentioned. Thank you.